I want to thank everybody for coming to the afternoon session. My name is Judy Christeller. I'll be your moderator and I'll be your speaker. So we're in this for the next 3 hours, 3 hours and 10 minutes. I'll tell you a little bit about myself. I work at Wilkes University. I've been there for 11 years. I'm an associate professor. Before that, I graduated from University of Kentucky with my PharmD, and I did a residency in critical care at Herman Hospital in Houston, Texas. So I'm going to have two presentations. The first is fluids, electrolytes, and nutrition, and then the second one is going to be critical care. So we'll go ahead and get started with fluids, electrolytes, and nutrition. I have no conflicts to disclose. So here's the agenda for this particular topic. We're going to talk about the distribution of total body fluid. We're also going to talk about fluid resuscitation, what that means, how we do it, and how does that compare to maintenance IV fluids. We'll talk about the differences between crystalloids and colloids. What are they? When should we use one over the other? We'll talk about the osmolarity of intravenous fluids, and you already know how to calculate it. You've learned it at one point in your career, so I'm going to refresh your memory on that and remind you that it's not very hard to do. And we'll talk about why it's relevant, the osmolarity. We'll talk about hypertonic saline, and that's going to lend to a discussion of treatment of hyponatremia and how to appropriately treat it. We'll talk about hypotonic fluids, and that will then bring us to hypernatremia and how to treat that. We'll talk about hypo and hyperkalemia, some other electrolytes and drug shortage issues that are common with electrolytes especially. And then we'll talk a little bit about enteral and parenteral nutrition. When we get to the critical care section, we'll talk a little bit more about enteral and parenteral nutrition as it relates to critically ill patients as well. So I'll start off with a question from your book on page 120. A 74-year-old female with a cough and a fever to 102, and she's lethargic. Her blood pressure is 72/40 with a heart rate of 115 and urine output of 10 mils per hour. She has a white count of 18,000 and a creatinine of 1.7, which is up from her baseline of 1.2, and she weighs 72 kilos. She's given a 500 ml bolus of normal saline, and her blood pressure is then 80/46 with a heart rate of 113. Her chest x-ray is consistent with pneumonia, and she has a past medical history of coronary artery disease and arthritis. So you don't have to answer yet, but I want you to think about what's the best way to treat this patient. Should we give her some furosemide? Remember, she had a very low urine output, so maybe that's the way to increase her urine output. Should we give her 5% albumin, 500 mils, in addition to norepinephrine, and titrated to a systolic blood pressure of 90 or higher? Should we give her a 1,000 ml bolus of D5 normal saline? Should we give her a 1,000 ml bolus of normal saline? So before we answer that, we're going to think about a few different things. The first is, how do we recognize intravascular volume depletion? And how do IV fluids distribute in total body fluid, and specifically in the intravascular space, and why is it important? And what IV fluids can be used to optimize this intravascular volume? So we're going to start with total body fluid. And what I've shown you here and also in your book is that total body fluid is separated into different fluid compartments. We have an intracellular compartment, so most of our fluid is inside the cells. 60% is inside the cells, and 40% of fluid is outside of the cells, or the extracellular. You might see in other references, besides 60-40, you might see 2/3 and 1/3. It doesn't really matter. It's all kind of an estimate, so you get the gist of this. And think about what separates the intracellular from the extracellular environments. The cell wall. So keep these numbers in the back of your mind because they're going to come up again. That extracellular space is then further subdivided into the interstitial space. This is the stuff that bathes the cells. okay? And it's also divided into the intravascular space. So 25% of the extracellular fluid is intravascular and 75% is interstitial. So what separates those two compartments between the intravascular and the interstitial is that capillary membrane. And that's why there's this dotted line around interstitial, because it's a semi-permeable membrane. So it's important to think about these percentages, but also what separates these fluid compartments so that we can think about how fluids distribute between them. So if we think now just about that intravascular space, it's not exactly all extracellular, because within that space there's cells, red blood cells. So the extracellular fluid inside this intravascular space is called plasma, and there's about 3 liters of plasma. And then there's an additional 2 liters of fluid inside our red blood cells, making the total blood volume right around 5 liters for most people. The intravascular fluid is similar to the fluid in your car's gas tank. So let me give you this analogy that if you go drive your car to the gas station and you take the pump and fill up the back seat of your car with gas, your car could be full of gas, right? We're not going to go do that. You put it in the gas tank because that's what makes your car go. So we likewise can be full of fluid, but if it's not in our intravascular space, then our pump, our heart, doesn't work as well. And I can show you that with the Starling curve. You guys all remember the Starling curve from school? You love it, I know you do. So on the one axis is cardiac output. That's how well your heart is functioning. And on the other axis is any measure of intravascular volume. So don't be confused by this. I'm going to use the pointer over here. Sorry, you guys on the other side of the room. Don't be confused by these abbreviations: central venous pressure, left ventricular end diastolic pressure, or mean arterial pressure. These are pressures which indicate volume. The more volume, the higher the pressure. So you can see as you increase your pressure, you increase your cardiac output. Your heart functions better. So what we want to do is we really want to be sitting at the top of our Starling curve, and that's where our heart is working the best. And if we have an intravascular volume depletion, if our tank is not full, then our heart doesn't function as well, our pump doesn't work as well, and we have hypoperfusion and all kinds of problems and organ dysfunction. So you want to keep your tank full, your intravascular space. Interestingly enough, we actually don't sit right at the top of our Starling curve right here. We actually sit kind of just to the left of it, and that's because our bodies are made so perfectly so that, for example, if we have to go run out of this building, which I hope we don't have to do, we have some extra energy to do that. So we sit just to the left of it. But the point is that if you optimize your intravascular volume, you optimize your heart function. And if you have too much volume, you see that your heart function starts to decline as well. So now let's think about how IV fluids like crystalloids distribute in our total body fluid. Crystalloids are examples of crystalloids are normal saline, lactated ringers, and even though they're different, and the differences are described in your book, they behave similarly in terms of how they distribute in total body fluid. So they behave clinically the same. So for normal saline or lactated ringers, they contain mostly sodium and chloride for lactated ringers. It's got some other things. Normal saline is all sodium and chloride. These do not freely enter the cells. Remember that that's what separates the intracellular from the extracellular space. So they're going to stay in the extracellular space. They're going to distribute evenly in that extracellular space. So if you remember, it's 25% intravascular and 75% interstitial. So for every 1,000 mils, you're going to get approximately 250 mils of intravascular volume replacement, or that's the amount of fluid that goes into your gas tank, okay, into your intravascular space, and that's what is meaningful to us in terms of perfusion. If we look at dextrose, 5% dextrose, it's metabolized to water and carbon dioxide. And dextrose, water, when it's metabolized to CO2, we breathe that off, we exhale that, and the water can cross any membrane. This is why in 1990s, when I was in pharmacy school and they said dextrose is free water, and I never understood what they meant by that because it's not water, so I didn't get it. This is why dextrose is free water, because it crosses any membrane. It goes wherever it wants to go in terms of how it distributes in total body fluid. It's free to cross any membrane. So each liter then is 60% intracellular, 40% extra, and then if you do the math, you get about 100 mils of dextrose or fluid that remains in your intravascular space. Okay, so that explains why dextrose is not a great fluid for resuscitation because it doesn't give you as much intravascular volume replacement as does normal saline or lactated ringers. So now let's think about colloids. You've heard about the arguments between crystalloids and colloids. Colloids are theoretically too large to cross that capillary membrane that separates the intravascular from the interstitial space. So for every 500 mils of colloid that you infuse, it should pretty much stay in the intravascular space. You should get about 500 mils of intravascular volume replacement. So what are some colloids? The most common is packed red blood cells. Blood is a colloid. So that will all stay in the intravascular space. Also, we have pooled human plasma, or 5% albumin, plasma protein fraction, or plasminate. There's also a semi-synthetic glucose polymer known as dextran, or the semi-synthetic hydroxyethyl starch, or HETA starch, which I'll talk about a little bit later, which we don't use as much anymore because of its association with kidney injury and mortality. So for IV colloids, there's also, in addition to 5% albumin, there's 25% albumin. And this has a higher oncotic pressure, and so it's going to draw fluid into the intravascular space. So it's going to result in volume expansion of about 5 times the volume that you give. If you give 100 mils, you should get about 500 mils of intravascular volume expansion. You want to be careful because this fluid redistribution can actually cause cellular dehydration. You're taking fluid from your cells and moving it into this intravascular space. It might be useful in patients that have ascites or pleural effusions where fluid redistribution is the goal. You want to move fluid from your belly or from your lungs into your intravascular space and hopefully then eliminate it. So for fluid resuscitation, intravascular fluid depletion is commonly due to hemorrhagic shock or septic shock. So for hemorrhagic shock, we can understand why we lose intravascular fluid. But for septic shock, it's not as intuitive. And we'll get to that a little bit more later on. But basically, you have vasodilation and you have inflammatory mediators causing fluid to shift out of your intravascular space. So it's still in your body. It's just not in your intravascular space, and it shifts into your interstitial space. And that's why many patients with septic shock are very edematous, because they have fluid. It's just not in their tank. So some signs and symptoms of intravascular volume depletion occur when you have about 15% of your volume lost, or right around 750 mils. And these symptoms are hypotension, tachycardia. You can have a reduction in urine output. One of the best signs, though, is when you give a fluid bolus, their parameters improve. And so that's one of the best indicators of intravascular volume depletion, is when you give them a bolus of fluid and things get better. That's essentially the patient saying, "Thank you, I'll have another." Some other signs and symptoms are reduced cardiac output and evidence of organ hypoperfusion, which can lead to organ dysfunction and death. So this is when you get into a higher mortality rate with patients. You need prompt intravascular fluid replacement. It has to be fast, as soon as you can get it in. It goes through a central venous catheter, because if you put it in a peripheral catheter, you can't get it in fast enough. So you want a central line, you want the fluids to go in as fast as possible, and you're going to give a lot. This is not the time to give 100 mils per hour or 200 mils per hour. You give that whole 500 to 1,000 mils. I say that range because for the older patients, with heart disease, maybe heart failure, I'm going to be a little bit more cautious with them. But for a younger patient or a patient without any evidence of heart failure, I'm going to be a little bit more aggressive in terms of let's give them a liter at a time. And you give this as a bolus, and then you reassess. And you keep doing that as long as their signs and symptoms are improving. So what do we give, crystalloids or do we give colloids? It sounds like, based on what we talked about for the distribution of colloids, since they all go into your intravascular space, it sort of sounds like they would be better. But crystalloids, normal saline or lactated ringers, are also recommended. So lactated ringers, it's historically used in trauma patients because the lactate's metabolized to bicarb. And this is theoretically useful as a buffer for patients with metabolic acidosis. But there's no evidence of superiority of one over the other. Patients might develop metabolic acidosis if they have shock because they have decreased perfusion to their tissues, so they're getting less oxygen, and that can create a metabolic acidosis. Even though colloids seem better than crystalloids based on the distribution, there's no evidence to demonstrate that any outcomes are improved. There's no evidence to show that patients are on the vent for a shorter period of time, that they have improved mortality, that they get out of the ICU or out of the hospital faster. And the colloids also have a much higher cost associated with them. So colloids are popular, but they're controversial because there's a lack of evidence to demonstrate that they're better. So I put these slides in and added them to your notes. This is not evidence-based, but this is what many do in practice in terms of how they use colloids. So you could consider albumin after fluid resuscitation with crystalloids, usually in the range of about 4 to 6 liters, but some people would say more, some would say less. After that's failed to achieve your hemodynamic goals, or when clinically significant edema limits the further administration of the crystalloid. So maybe they're having pulmonary edema and it's making it difficult to oxygenate that patient. And that might be an opportunity where you would think of albumin. You might also consider albumin if a patient has a low albumin concentration, although we know that this fluctuates with stress, and they have required a large volume of crystalloid. You should avoid head-starch, like I said, because of the risk of kidney injury and increased mortality. Also consider albumin, preferably the 25% theoretically, in conjunction with loop diuretics for patients with clinically significant edema and a low albumin concentration less than 2.5 when appropriately dosed diuretics are ineffective. So the examples that you've probably seen in practice are patients with pulmonary edema or pulmonary effusion causing respiratory failure or symptoms. And you want to improve, you want to decrease that fluid that's accumulated in the lungs by giving them albumin and then a diuresis to improve their respiratory status and maybe either extubate them or prevent intubation. So this is an approach that you might see being used. Again, there's not evidence to support it, and theoretically, I have a little bit of a problem with it because loop diuretics are highly protein bound. So if you do administer them with albumin, then theoretically they're just going to bind to the albumin and they're not going to be as effective for that. So we've talked about fluid resuscitation. Now we're going to talk a little bit about maintenance IV fluids. These maintenance IV fluids, the big thing is that these are not for patients who have signs and symptoms of intravascular volume depletion. So when you're asked for a stat D5 half normal saline with 20 of K for a patient who has a low blood pressure, you need to think, well, maybe that's not the most appropriate IV fluid for this patient. Okay? So IV fluids need to be reevaluated on a daily basis based on the clinical scenario. And if patients are having signs and symptoms of intravascular volume depletion, they should not be on D5 half with 20 of K. That's a typical IV fluid. You can omit the potassium if they have an elevated potassium or kidney failure. There's no magic to this. There's not any, it has to be this amount. It's just a normal type of fluid for patients that can't take fluids in orally. It's a little dextrose, it's a little sodium and chloride, and a little potassium to maintain homeostasis. Normal saline and lactated ringers or colloids are not appropriate for maintenance IV fluids. That's not a natural fluid that we would be taking. And you want to evaluate them daily and discontinue them when patients can tolerate oral fluids. How much fluid do we give? For resuscitation, we're going to give this bolus dose of 500 to 1,000 mils and then reevaluate, and we're going to keep doing it and as long as they're getting better with that. One patient could need 2 liters, another patient could need 12 liters. So it's going to be patient-specific, and you have to continually reevaluate them. For daily fluid maintenance, again, there's not any magic to it. Many use 1,500 mils for the first 20 kilograms and then 20 mils per kilogram thereafter. Comes to about 2,500 mils per day or right around 100 mils per hour. You want to adjust that rate based on their ins and outs. If they're retaining a lot of fluid, you would decrease that. And also their estimated insensible losses. So patients that have a fever lose a lot of fluid through their skin. So you would want to give them more IV fluids. Or if they have drains or a lot of diarrhea, you want to replace their fluid. So for this particular patient that we had with the patient who's hypotensive, she's got decreased urine output, an elevated creatinine. We gave her a bolus of normal saline. So now what would you like to do? Do you want to give furosemide, the albumin plus norepinephrine, the D5 normal saline, or normal saline? Do you want to hold up your cards? Good. So I'm seeing mostly yellow for the bolus of normal saline. So even though we didn't choose furosemide, let's see from a show of hands how many people have seen prescribers do this, give furosemide for patients with signs. Does anybody see that? Nobody sees that? Oh, a few. I see it all too often where the urine output is decreased and it's kind of a knee-jerk reaction. So you really have to avoid that impulse to give a loop diuretic for somebody who has decreased urine output. The urine output is decreased because their intravascular volume is decreased. And so a loop diuretic can actually be harmful in this case for these patients. The albumin you would want to reserve. You want to try crystalloids first, and you also want to reserve the vasopressors. We'll talk about that later. You want to try to give fluid resuscitation first as well. In general, you don't give bolus of anything with D5, so that's just going to complicate matters. That's why dextrose is not a fluid resuscitation. You don't give D5 normal saline. Even though you're still giving normal saline, you don't want to complicate matters with giving a bolus of dextrose, and then you have the hyperglycemia that you could have with that as well. So now we're going to move on to plasma osmolality. A normal plasma osmolality is between 275 and 290 milliosmoles per kilogram. And the primary determinant of plasma osmolality is our primary extracellular cation, which is sodium, and then it's anion. So I can prove this to you that this is the primary determinant of osmolality because a normal serum sodium of 140, if that dissociates into its anion, you take 2 times 140, that's 280. That's the primary determinant. There's other things that determine osmolality, like a little bit from potassium, a small amount from glucose, assuming your glucose value is normal, and BUN. But those have a really minor role. It's primarily determined by sodium. And that's a really important point because shifts in sodium can be very dangerous. So changes in plasma osmolarity cause fluid shifts across cell membranes. If you have an increase in your osmolality, it causes cellular dehydration as the fluids shift across that membrane. If you have a decrease in osmolality, you can have cellular swelling, and cells could rupture, and that could be life-threatening as well. This can cause permanent neurologic damage and even death. So major changes not only in osmolality, but in serum sodium can result in changes in osmolarity, and these can also can cause permanent neurologic damage and death as well. So if we calculate the osmolarity of IV fluids, and in the book, I've talked about the difference between osmolality and osmolarity. I've described that in there. So the osmolarity of IV fluids, an IV fluid is isotonic. With isotonicity, there's no osmotic gradient. There's no fluid shifting across cell membranes. For hypertonic IV fluids, you get cellular dehydration and shrinkage, and for hypotonic IV fluids, you can have cellular overhydration, and this can occur if your osmolarity is less than 150 milliosmoles per kilogram. This can cause red blood cell swelling and hemolysis. You can also have brain cell swelling, which can cause cerebral edema and herniation and death. So how do we calculate osmolarity of IV fluids? If we look at normal saline, I'm going to prove to you here that it's isotonic. You need the 0.9%, and I convert that over to grams per liter, or 9 grams per liter. You need the molecular weight, so you have to look it up in either your Remington, or you can probably Google it and find it. So the molecular weight of sodium chloride is 58.5. You could, if you really, really wanted to impress people, you could look up the osmotic coefficient of sodium chloride, which is 0.93. And basically this means that in solution, sodium and chloride doesn't completely or 100% dissociate. There's still an ionic attraction between the sodium chloride. So it's 93% dissociated, but 7% is still hanging out together. Clinically, it's probably insignificant. So if you can't find the osmotic coefficient, I wouldn't lose any sleep over it. But basically then you can do the math and using these parameters, and you can calculate that based on the concentration of the sodium chloride, the molecular weight, and knowing that sodium chloride dissociates into 2 osmoles or 2 osmoles per mole, and then multiplying by the osmotic coefficient, you get 287 milliosmoles per liter, which is similar to our plasma osmolality, which is isotonic then. So now we're going to talk a little bit about hypertonic saline and hyponatremia. So here's the patient case number 3 from page 134. This is a 72-year-old female with hypertension. Started hydrochlorothiazide 3 weeks ago with dizziness, fatigue, and nausea. Her sodium is 116. She weighs 60 kilograms. Her blood pressure is 86/50, and her heart rate's 122. By the way, this is a common presentation of elderly patients on a thiazide diuretic, and hyponatremia can develop within the first few weeks of it. So for the treatment of this patient, what do you think is best? Should we give her normal saline at 100 mils per hour? Should we give her a 500 mil bolus of normal saline? 3% saline at 60 mils per hour, or 23.4% sodium chloride, the concentrated sodium chloride, a 30 mil bolus as needed? What do you think? I see some green, I see some red. I see red and green. Oh, I see a blue. All right. Before we answer that question, I'm going to ask you another one. What's the treatment goal for the first 24 hours in correcting her serum sodium? Her initial value, remember, was 116. Do you want to get her to 140, 132, 126, or somewhere between 116 and 120? Where do you want her? I see a lot of green, a little bit of yellow. All right, let's talk about it. So we're going to start by talking about hypertonic saline, and then we'll come back to that case. What you're going to see with hypertonic saline is 3%, 7.5%, or 23.4%. These are the most common preparations of it. The 23.4 is obviously that concentrated electrolyte. The osmolarity, if you calculate it and do the math, which you can all now do, you would calculate it to be 950 for the 3% and then 2,400 and 7,400 respectively. This is right at that cutoff for what you can give for a central line administration because it starts to be very irritating to the veins. So you should give this through a central line if you're giving hypertonic saline. I get at least once a year on the critical care listserv through ACCP, somebody always throws out the question, can you give hypertonic saline, meaning the 3%, through a peripheral access? And I think the bottom line to that is if you have central access, you should give it centrally. If you've got an emergent situation where you have to give hypertonic saline and you only have peripheral access, then it's probably okay for a short period of time until you can get central access. But that right around 900 milliosmoles per liter is that cutoff for what we shouldn't give peripherally. We should give that centrally. It's used for patients with traumatic brain injury to reduce an elevated intracranial pressure, or ICP, and also increase their blood pressure. For this, you'll see all three different strengths recommended in the trauma literature, the 3, the 7.5, or the 23.4% saline. It's also used for symptomatic hyponatremia. For this, you usually will use the 3%. And most protocols incorporate a 3% saline. This is usually acute, and by that I mean the symptom onset is within about 3 days. And symptomatic, what I mean by that is these are patients that are experiencing lethargy, psychosis, seizures, or coma. So here are some symptoms of hyponatremia. And really, you don't start to see some of the more severe until you get below 120 milliequivalents per liter. And above that, the symptoms are usually mild for hyponatremia. Hypertonic saline is not for a few things. And I see, and maybe you do as well, I see this being used inappropriately in hospital settings. And so that's why I have this slide. This is what it's not for. It's not for chronic asymptomatic hyponatremia. Okay? So we don't need to do that knee-jerk thing where we just try to replace the sodium and fix it. Examples of this would be SIADH. This is usually chronic, and it's treated with fluid restriction. It's also not for hyponatremia secondary to diabetic ketoacidosis. As your glucose is corrected with DKA and as your fluid is replaced, then your sodium will usually correct as well. It's also not for hyponatremia associated with heart failure. This is, again, usually chronic. It's usually asymptomatic, similar to SIADH. If patients are symptomatic from this, then you have to be really careful using, for volume overload, using hypertonic saline. Here's an error that you might have seen because of the, now we're using, over the last 5 or 10 years, we're using more bicarb infusions. And most people will take 150 milliequivalents of bicarb, which has 150 milliequivalents of sodium, and mix it in 850 mils of IV fluid. This has been used to prevent radiocontrast nephropathy. If you mix this in normal saline, then the result is equivalent to 3% saline. So that's hypertonic, and that's an error. I suggest mixing it in D5W. You could use sterile water. I just always have a fear that you're going to think you put the sodium in, but you really didn't. So I have that fear of accidentally dispensing sterile water where the sodium bicarbonate has not been added to it. So to avoid that error, I prefer to mix it with dextrose. Yes, the osmolarity is higher, but I don't know that that's really clinically significant. So what is the safe use of hypertonic saline for patients with symptomatic hyponatremia? Your goal is a small but quick rise in your sodium, by about 0.75 to 1 milliequivalents per liter per hour to get them up to a concentration of 120, which is usually a safer range. Okay? And then you want to decrease your infusion to about 0.5 milliequivalents per liter per hour. You want to slow it to a rise in your sodium by about 0.5 milliequivalent per liter per hour. You can achieve this using 3% saline at 1 to 2 mils per kilogram per hour, or you can give a small bolus of 250 mils over about 30 minutes. You treat them until their symptoms stop, their symptoms of acute hyponatremia, or they've reached a safe range of their serum sodium within that 120 to 125 range. And also, you don't want to treat them to you don't want them to have more of a maximum change in their serum sodium. I'm going to explain that more on this next slide. So the maximum change of your serum sodium is 10 to 12 millimoles per liter, which is the same thing as milliequivalents per liter. They're synonymous, in 24 hours. You don't want your serum sodium to change by more than 10 to 12 millimoles per liter in 24 hours. Rapid correction of serum sodium can cause, remember I said this is the primary determinant of plasma osmolality, and if you have rapid changes in osmolality, you have fluid shifts. And this can cause central pontine myelinolysis, or more globally, it's known as osmotic demyelination syndrome. So it's not, that's the more accurate term, osmotic demyelination syndrome, because it's not necessarily the problem just limited to the central pontine area. This is characterized by paraparesis, quadriparesis, and coma. It can cause permanent neurologic damage. And this is the important point. The highest risk is in patients with chronic hyponatremia. Okay? So some things, like I said here, just don't need fixing. And I've seen this potential harm done many times. Many practitioners do not know the appropriate use of hypertonic saline. So some other considerations for patients with hyponatremia is that you want to look at the potassium and you want to correct if they have hypokalemia. Hypokalemia, that potassium is the primary intracellular cation. If you have hypokalemia, then sodium actually shifts into the cell in order to maintain the intracellular electroneutrality. So as you replace your potassium, your sodium will shift out of your cell and it will naturally increase. So you want to replace your potassium if you have hypokalemia in conjunction with hyponatremia. The other thing you want to think about is the volume status. So this is from Table 10 on page 132. And it's showing that for hyponatremia, patients can have an increase in their volume, they can have a normal volume, or they can have a low volume, hypovolemic hyponatremia. So for the first two, hyper and normal volemic, the primary treatment is to restrict fluids and treat the underlying cause. For hypovolemic hyponatremia, the treatment is now fluid resuscitation. And the reason for this is because hypovolemia, or intravascular volume depletion, is a stimulus for ADH secretion, antidiuretic hormone. This is going to cause you, this is going to perpetuate your hyponatremia. Once you restore their intravascular volume, then you'll slow down your secretion of ADH. So you treat these patients with fluid resuscitation the same way we talked about previously with normal saline. Once their ADH secretion is reduced, then their serum sodium can rapidly correct. So you could actually too quickly, and you can increase sodium too quickly with just fluid resuscitation with normal saline. So you have to be very, very careful about those patients that have hypovolemia and hyponatremia. Because you could cause, again, permanent neurologic damage by overly correcting or too rapidly correcting their serum sodium. So for this particular patient, The answer, many of you said, was to give them normal saline, to give them a 500 ml fluid bolus with normal saline, and this will decrease the secretion of antidiuretic hormone because it gives them fluid resuscitation. The goal for the serum sodium for this patient would be 126, which puts you within that safe range, and it's also within the maximum change that you can achieve with your serum sodium within a 24-hour time period. So also on table 10 from this table of hyponatremia, I mentioned Vaptans as a treatment of hypervolemic or normovolemic hyponatremia. So the next couple slides are going to talk about the Vaptans. So these are vasopressin receptor antagonists. And this is on page 133. It jumps around just a little bit. The arginine vasopressin secreted by the hypothalamus regulates your plasma osmolality. The products available are IV conivaptan or oral tolvaptan. These have been shown to be safe and effective for normovolemic, such as SIADH, or hypervolemic hyponatremia. Example would be heart failure or cirrhosis. And this hyponatremia that persists despite fluid restriction. These drugs can facilitate an aquaresis, so it promotes the elimination of fluid without the electrolytes. It's an electrolyte-free water excretion. They can increase your serum sodium, and they can alleviate symptoms and reduce weight in patients with heart failure. The problem with the Vaptans is that there's no evidence of improved clinical outcomes in prospective randomized controlled studies. So what would be a clinical outcome? I would like something even on the realm of fall prevention. If they've been shown to prevent falls in elderly patients because of the side effects of hyponatremia, I think that would be a beneficial thing. Let alone decrease hospitalizations, decrease hospital length of stay, and improve mortality. Those would be ideal. They also are substrates and inhibitors of cytochrome P450-3A4 enzymes, so you have to monitor for drug interactions. If you combine these drugs with a 3A4 inhibitor, this could increase the effect, leading to a rapid increase in serum sodium. Fluid restriction in combination with these drugs during that first 24 hours can also increase the risk of overly rapid correction of serum sodium. So you want to avoid fluid restriction within the first 24 hours of using these drugs. So now we're going to switch gears and talk about an opposite problem, hypernatremia. And this is a real case that I see actually regularly. This was a real case, but I've seen this even since then. A 74-year-old female on Gevity tube feedings at 60 mils per hour for 8 days through her PEG feeding tube. She weighs 50 kilos. She's had a recent stroke, and she's not able to communicate with us. Her sodium gradually increases over the next several days from 142 to 149 to 156 to 163 on days 3 through 8. What's the treatment for this patient? So we're going to talk about that. We're going to now move to hypotonic fluid and the treatment of hypernatremia and the prevention of hypernatremia. So you remember the 90s when we had the albumin shortage? Maybe it was the 80s. Was it the 80s or the 90s? It was a long time ago. And we took albumin 25% and we diluted it with sterile water to make albumin 5%. That has an osmolarity of 60 milliosmoles per liter. And there are case reports of death with that. It's associated with red blood cell hemolysis and death. Okay? That we know. Quarter saline. You guys see those orders for quarter saline? I hate those orders. It's hypotonic. It has an osmolarity of 68 milliosmoles per liter. You could all do the math, okay, whether you use the osmotic coefficient or not. It's a low osmolarity. You should avoid IV fluid with an osmolarity less than 150 milliosmoles per liter. IV fluid. So what's the appropriate use of hypotonic IV fluid? I can't think of any. The only appropriate use of hypotonic fluid is to drink it. Okay? We shouldn't give it intravenously ever. I think I will do that now. Observe. So for the people that are listening on the home CD-ROM in your pajamas, I just took a drink of water. Okay. So is hypernatremia a good reason to use hypotonic saline? Patients with hypernatremia need water. They don't need sodium and chloride. Okay? But we never give water intravenously because it has an osmolarity of 0. So, if possible, give it by mouth. If you can't give it by mouth, you can give free water, or D5W, which is metabolized to water, but it's isotonic. The osmolarity of D5W is isotonic with our plasma. So, what should you do with those orders for quarter saline? I've got a whole plan of attack for this. First of all, it's a potentially fatal error, but I don't have any evidence to support that, okay? Other than the fact that other solutions with a similar osmolarity have caused death. It's usually ordered in error because they don't really understand the pathophysiology of hypernatremia and that the patient needs water. You can eliminate the risk by changing this to D5W. That's the best case scenario if the patient needs intravenous fluids and can't take water orally. D5 quarter saline, that's a recommendation that I found is more likely to succeed. And it's not terrible because you can actually slow down the rate of change of your serum sodium. So that's if they won't use D5W or you're concerned with the rate of change of your sodium, then you can switch it to D5 quarter. If they complain that, well, 5% dextrose, I don't want to cause hyperglycemia, then you can, okay, well then how about D2.5 quarter saline, because that also has an osmolarity that's fine. You could add KCl to it, and that will increase the osmolarity of it. But enteral water would be the best case scenario. If none of those succeed, I don't know what to do. Treatment of hypernatremia. Rapid correction of chronic asymptomatic hypernatremia is potentially a fatal medical error. If patients are symptomatic, the serum sodium should be corrected no more than 10 to 12. It's the same thing for hyponatremia. And you want to replace their water deficit slowly over several days. So how do you calculate a water deficit? There's an equation for women and for men, and this equation it uses lean body weight, which many equate with ideal body weight. You want to replace it slowly, following the guidelines for safe change in your serum sodium. And if your serum sodium is changing, changing too rapidly, then you could give D5 quarter or D5 half normal saline to slow down that rate of decrease of your serum sodium. So for this particular patient, what do you want to give? She's got a serum sodium of 163. What do you want to give? Sterile water, intravenously, D5 quarter, or water through the PEG tube, 200 mils every 6 hours. Excellent. A lot of yellow. So we never give sterile water intravenously. D5 at 80 mils per hour would be an option if you can't give water enterally. D5 quarter would be an option if the serum sodium is decreasing too fast, and enteral would be your first choice. By the way, the hypernatremia in the setting of this particular patient is completely preventable, and it should be considered a medication error. It can be prevented by being proactive with the enteral administration of water in patients that are receiving tube feedings, especially if they're receiving concentrated tube feedings that provide 1.5 or 2 calories per ml. You want to check the label of your tube feeding, and you want to talk to your dietitian, and you want to give the patient usually around 1 ml of water per calorie administered, but most tube feedings, a liter for 1 calorie per ml, a liter of tube feeding might contain 750 to 850 mils of water. So you're going to need additional water to give to that patient in addition to what's provided in the tube feeding. This is especially important in patients that can't communicate thirst. We don't become hypernatremic because we drink when we become thirsty, but if they can't communicate thirst, like elderly patients with some neurologic problems or babies, we have to give them water. And if we don't give them water, it's an error. We're not doing our job. And it's very uncomfortable. Can you imagine? When you're thirsty for water, can you think of anything else besides drinking water? So we shouldn't do that to our patients. When we have to watch their serum sodium and make sure that we give them enough water. I'm going to move on to potassium. It's the primary intracellular cation. So all the values that are low numbers on your chemistries are primarily intracellular. So the value that you see is kind of the tip of the iceberg of your total body potassium, the value that you see on your chemistries. And the balance between intracellular and extracellular potassium is maintained by several different things. It's maintained by beta-2 stimulation. This causes cellular uptake. Insulin promotes cellular uptake of potassium. And your plasma potassium concentration will cause a passive shift in or out of cells based on that concentration. So for hypokalemia, which is defined as a potassium less than 3.5, this is seldomly caused by a decrease in potassium intake. Because if you decrease your intake, then your kidneys are just going to decrease excretion. Some causes of it are, one, a shift of potassium into the cells, and this can occur with an increase in your pH, so alkalosis, an insulin or a carbohydrate load, beta-2 stimulation like stress or drugs, or hypothermia. And we'll talk a little bit about that in the critical care section when we talk about inducing hypothermia and the effects on potassium. Also can be caused by gastrointestinal losses with vomiting, diarrhea, fistula, laxative abuse, or urinary loss with diuretics, which we see more commonly. Also, a low magnesium will cause an increase in your potassium loss through your kidneys. So if your magnesium is low, you're going to lose potassium. So the treatment pearls of hypokalemia. How much to give? Everybody wants to know how much to give. Remember, your potassium value is the tip of the iceberg. So you can't look at that value and say, oh, if your potassium is 3, that means you're low by about 100 milliequivalents. You can't tell. It's the tip of the iceberg, and there's a lot of potassium underneath that. So you guide your potassium replacement by your plasma potassium concentrations. You give some, you recheck. You give some, you recheck. So it's guided by that rechecking. How fast do we give it? 10 to 20 milliequivalents per hour, a max of 20 to 4 milliequivalents per hour. That maximum rate would require continuous EKG monitoring, regardless of the route. So if you're giving a sustained release product orally, then it's going to be a nice, slow administration. But if you're giving an immediate release, like that really nasty tasting potassium liquid, you guys tried that? It's disgusting. If you give that, you're still limited by that rate of 10 to 20 milliequivalents per hour. It's very rapidly absorbed throughout your gastrointestinal tract. So from a safety perspective, you need to be careful when you're giving that immediate release potassium. The route, we should give it orally if the patient is not having symptoms, especially considering all of the shortages that we've had. If you're giving it peripherally, the maximum concentration is 60 milliequivalents per liter. So now, treatment pearls of hyperkalemia. The first thing you want to think about is that potassium value real? Does it fit your clinical scenario? Potassium can be artificially elevated if you've had a traumatic vena puncture because of red blood cell hemolysis. It can also be artificially elevated if the serum rather than the plasma potassium was checked because the potassium is released during coagulation. So you could have a falsely elevated potassium. So if it doesn't really fit your scenario, then you would definitely want to recheck that. You also want to ask yourself, is the patient experiencing severe muscle weakness, or are they having EKG changes like peaked T waves or a wide QRS? Or is the potassium greater than 6.5? VFib, or potentially fatal ventricular arrhythmias, can be your first sign of hyperkalemia. If none of those, if you don't answer yes to any of those questions, you can give Kayexalate. If yes, then you want to think a little bit more about urgent treatment of hyperkalemia. The first thing you're going to do is give calcium gluconate, 1 to 2 grams over 2 to 10 minutes. This is not going to lower your potassium, but it can prevent hyperkalemia-induced arrhythmias. I'm going to come back to calcium gluconate in a little bit because I know that there's some shortage issues with it. There's also then, after calcium gluconate, drugs that can cause an intracellular shift of potassium. The first you're going to use is insulin, 10 units IV. You can give it with glucose to prevent hypoglycemia, but if the patient is already hyperglycemic, you don't have to give it with glucose. This effect is usually within 60 minutes. Sodium bicarbonate, 50 milliequivalents, this effect is within 30 to 60 minutes, although the efficacy is disputed and it's not as consistent as with insulin. And then albuterol, or the beta-2 agonist, that effect is slower, within 90 minutes. It's also just inhaled in this country. It's only available in this country as the inhaled formulation. 40% of patients will not respond to this. So if you're going to use this, you would use this in combination with insulin. Insulin is the mainstay of treatment in addition to calcium gluconate. After you have treated the urgent hyperkalemia, you can increase potassium excretion with diuretics. This will increase renal excretion if the patient has functioning kidneys. Many times they don't, because this is fairly common in patients with kidney disease. You can also use a cation exchange resin such as Kayexalate orally or as a retention enema. I've got more on that coming up. Or you could use dialysis. So now we'll focus a little bit on Kayexalate and sorbitol, mostly because in years past, after this talk, I would have like 20 people coming up here asking me just about Kayexalate and sorbitol. So it's all on the slides now. You can still come up and talk to me, but I've tried to talk about it here. So there are many reports of bowel injury with both oral and rectal administration of Kayexalate mixed in sorbitol. It's linked supposedly to deposition of drug crystals in the GI tract and damaging the mucosa and causing necrosis. The most reports are with the 70% sorbitol and not the 33%, and that's the current pre-mix suspension is the 33%. The risk of colonic necrosis is rare with that formulation. You also want to use caution in patients with kidney or heart failure due to the sodium retention with this. So this is not in your notes, a little bit more on Kayexalate. There was a recent, I've given you the reference here, from just this year, 2013, a recent paper on this. No controlled trials have demonstrated efficacy of Kayexalate, and the author kind of describes this, how it was approved in 1958 before the FDA required manufacturers to demonstrate efficacy. It's just interesting. And this systematic review found that sodium polystyrene without sorbitol is also associated with colonic necrosis. So they're really advocating for not using this drug whatsoever. It's an interesting article. So now a little bit more on calcium use in patients with hyperkalemia. The gluconate can be administered peripherally, and it's preferred over calcium chloride because of the reduced risk of tissue necrosis. We know that 10 mils of 10% is equal to 1 gram or 90 milligrams of elemental calcium. I have this on here because it's different for calcium chloride. There's a different amount of elemental calcium and calcium chloride. So if you use calcium chloride, you have to adjust the dose. Calcium chloride can be used if you have central IV access, but again, you want to adjust the dose. And again, the calcium will not reduce the potassium, and you want to avoid calcium if you've got a patient who's on digoxin. This can increase your risk of digoxin toxicity. So this is kind of a combination of other electrolytes that is on pages 141 to 143, and it's focusing on replacement of other electrolytes. So the first is with magnesium. When you want to replace magnesium, you can use oral magnesium, but a limiting factor is diarrhea. If patients are symptomatic, they're having symptoms including tetany, seizures, or hypertension, you can administer 1 to 4 grams IV slowly, about 1 gram per hour. If you administer it too rapidly, you can cause hypotension. The other thing, if you administer magnesium rapidly, intravenously, then you excrete it rapidly. So the slower you give it, the slower you infuse it, the more you'll hold on to it. So you will increase renal excretion if you administer it rapidly. If a patient has torsades or something life-threatening, you can give it IV push. Moving on to hypophosphatemia. A major cause of a low phosphate is refeeding syndrome. I'm going to talk about that in a few slides. Also, you'll see low phosphate in patients with diabetic ketoacidosis. You can prevent refeeding syndrome by supplementing with 10 to 30 millimoles per liter IV. You'll have an increased risk of refeeding syndrome in patients that are malnourished, patients that have alcoholism, also in patients with DKA. The oral form of phosphate is poorly absorbed, so you don't want to rely on this if you have a risk for refeeding syndrome, especially in those first few days, unless you have to because of a shortage. For calcium, for hypocalcemia, you don't treat, or you could use orally if a patient is asymptomatic, also associated with low albumin concentrations. Asymptomatic hypocalcemia can be treated with oral, and you don't give calcium chloride peripherally because it can cause limb ischemia. Some people have asked during the break if you can dilute calcium chloride because of the shortage of calcium gluconate. I don't know the answer if you can dilute it and then give it peripherally, but I know that some places are doing that. So also, in terms of electrolyte shortages, the Aspen Society has some nice recommendations about this. For the phosphate shortage, you want to reserve your phosphate for your peds and your neonatal patients. You also want to reserve it for DKA and refeeding syndrome. Interestingly, IV fat emulsions for patients receiving parenteral nutrition or other IV lipids contain 15 millimoles per liter as egg phospholipids. This is likely a sufficient amount of phosphate for most patients. For the calcium shortage, if you don't have gluconate, don't add calcium chloride to your parenteral nutrition. You want to try to use multi-electrolyte products, and again, it's unknown if you can dilute it and administer it peripherally. So now for the last section, I'm going to talk about enteral and parenteral nutrition. So the big thing with enteral and parenteral nutrition is thinking about the indication. For enteral nutrition, it's indicated in hemodynamically stable patients at risk of malnutrition in whom it's anticipated that oral feedings will be inadequate for at least 1 to 2 weeks. Notice it doesn't say 1 to 2 days. It doesn't say 3 to 4 days. It says 1 to 2 weeks. Most well-nourished adults without excessive metabolic stress can tolerate little to no nutrition for up to 7 days. Think about it. When you're sick, you usually don't eat. Maybe it's a good thing. I'm just saying. In terms of hemodynamic stability, you don't want to use enteral nutrition in those patients where you're also giving fluid resuscitation. You want to stabilize them. You want their blood pressure, their organ function. You want them to be stable before you start feeding them enterally. You're not going to do it within the first day or two of shock. So for delivery of enteral nutrition, there's gastric tubes that end up in your stomach. There's also tubes that end up in your duodenum or duodenal feeding tubes. You can have improved tolerance with duodenal feeding tubes. You can have a reduced risk of aspiration with duodenal feedings. The duodenal feeding tubes are narrower and they clog easier. And this is a real problem for nurses. So you don't want to go putting phenytoin suspension down them or suspensions that are going to clog them. You have to be careful about medication administration through them. You have to use continuous infusions for duodenal feeds because your duodenum is not a reservoir, right? So it's only your stomach that's a reservoir. You can't do bolus feedings into your duodenum. The continuous infusion is most common in hospitalized patients, and this is because it has a reduced risk of aspiration compared to bolus feedings. You might see bolus feedings used on an outpatient side or patients that are ambulatory that they want to get physical therapy and they don't want to be hooked up to a feeding pump. But in hospitalized acutely ill patients, we would use a continuous infusion. Even though it's not a normal way to eat, nobody eats as a continuous infusion. We all eat like a little bolus, right? So what are the formulations? You can have intact or polymeric formulas used for normal digestive processes. This is just normal nutrition, just in a liquid form. You can have elemental formulas for patients with malabsorptive processes, like short bowel. So these are sort of like partially digested or digested so that because you don't have all of your bowel to do the digestion. The elemental formulas usually have a higher osmolarity and they're a little bit more expensive. Normally, these formulas provide 1 to 2 calories per mil, so a typical formula is an intact or polymeric with 1 calorie per mil. There are specialty formulas that have been designed that are not necessarily associated with improved outcomes, but you'll see specialty formulas. So a renal formula is one for patients with kidney dysfunction. It's more concentrated, so you can give more fluid in a smaller volume or more nutrition in a smaller volume. It also has a reduction in protein and electrolytes. The pulmonary formula has more of the calories from fat and less from carbohydrates because the carbohydrates are metabolized to CO2 and H2O, and sometimes with pulmonary patients, if they're not ventilating, they can have an increase in their CO2 concentration. And then the diabetic formulas have more calories from fat, less from carbohydrates to get better glucose control, and they also have more fiber. So a typical example for a enteral nutrition is if you have a 60-kilogram patient that requires 25 calories per kilogram. That comes to a total of 1,500 calories. If it's 1 calorie per mil, your goal rate would be around 62 mils per hour, and you're going to start it at a slower rate, 20 mils per hour, and then you're going to advance it every 4 to 6 hours to your goal rate. So don't forget to add the water. UltraCal, in this example, provides 830 mils of water per liter. So if you're giving a patient 1,500 mils, you need to add an additional 250 mils of water daily. And so with your tube feedings, you would go ahead and order 60 to 70 mils of water per feeding tube every 6 hours as a water flush. And you want to make sure that this is getting done. So what are some complications of enteral nutrition? One is aspiration pneumonia, and for this reason, you want the patient's head of bed elevated to 30 to 45 degrees. You can hold if their gastric residuals are greater than 250 to 500 mils. So this is recent, this volume. In the last few years, this volume has increased. And there's also one paper that says we don't need to check residuals at all. But the residuals of 250 to 500 mils are still, it's still okay to continue tube feedings if they're below that range. 500 mils is a lot. So it's hard to convince some of the nurses and practitioners about this volume, but there is evidence to support this, that you don't have to hold the feedings if your gastric residuals are less than 250 to 500. Again, some recent evidence shows monitoring without measurement of residuals is safe, and there is no difference in the incidence of ventilator-associated pneumonia. And I have the reference on the bottom of this particular slide. This was just published in JAMA. You can consider pro-motility agents, although there's not evidence to show that these decrease your risk of aspiration pneumonia. And you can also consider duodenal feedings. So feeding past the stomach can decrease your risk of aspiration. Another problem with enteral tube feedings is diarrhea. It's more common with the higher osmolarity enteral feedings. It's usually kind of a battle between the dietitian and the pharmacist. Everybody's looking at the dietitian when there's diarrhea saying it's your fault, and the dietitian is looking at us saying, no, it's your fault, and it may be our fault. So some other reasons for diarrhea are antibiotics. It could be an infection. It could be a lactose intolerance. It could be that they're getting magnesium enterally or sorbitol or other sugars in syrups enterally. So a little bit about the pro-motility agents. Some of the options are metoclopramide, erythromycin. The dose here is 250 milligrams every 6 to 8 hours for 72 hours or until tolerating their enteral nutrition for 24 hours. You can combine these two, but you want to monitor for diarrhea with that. And discontinue if there's diarrhea. And you really want to avoid prolonged use or prophylactic use. Don't use them prophylactically because you have an increased risk of side effects. Both of these drugs have significant side effects and issues with use. So you want to avoid them and only use them if you need to. So enteral versus parenteral. We all have heard if the gut works, use it. The enteral feedings maintain the integrity of your gastric mucosa, and they can prevent bacterial translocation. This has been known since the 90s. Early enteral feeding improves outcomes in patients undergoing surgery. Again, that's also been known since the 90s. There is no evidence that early parenteral feeding improves outcomes. Parenteral nutrition, consider it if you're unable to feed a patient for at least 7 days with a non-functioning or inaccessible GI tract. So a little bit about the pre-mixed parenteral nutrition, because I did tend to get some questions on that in previous years. There's a great article that's referenced here for you that talks about pre-mixed parenteral nutrition. These are, there's different versions. So one is a 2-compartment bag containing amino acids on one compartment and dextrose in the other. This is available in the U.S. It's called Clinamix. It has electrolytes. You can add lipids to the container after you mix them together, or you could administer lipids through a Y site. Another option is procalamine. This contains, it's a 3% amino acid solution. It contains glycerin, which is similar to dextrose, but it contains 4.3 calories per gram, but it's a carbohydrate, and electrolytes. This is all in a single container. It doesn't meet the needs of most patients due to insufficient protein and calories. It's kind of equivalent to like a soda, except it's a lot more expensive. There's insufficient evidence to show that customized parenteral nutrition is superior to standardized premix. One of the problems I have with premix is they're just a little too easy to order. And I don't know if any of you have ever had these on formulary, but it's so easy. They can just write procalamine or the Clinomix and then a rate, and then boom, their patient's getting parenteral nutrition. And it may not be indicated, and most times it's not indicated. So they're just a little bit too handy. So ease does not always mean good. So there are pros and cons to these. The pros, obviously, we don't like making parenteral nutrition. There's a lot of manipulation. So for the premix, there's fewer manipulations. You have a decreased risk of contamination, decreased risk for compounding errors, decrease in your labor costs. It's a good fit for patients that are stable and have an indication. There's a non-electrolyte formula available, and it's also good when you have shortages. So for the formulas that have electrolytes or amino acids, these come in handy. The cons, you still need some additives like multivitamins and trace elements. If you have patients that have fluid restriction, this can be a lot of fluid. It's also not going to be adequate for patients that have high protein needs, like trauma patients or highly stressed patients. It's only 1 or 2 bags, so a standardized administration time becomes problematic if you start all of your parenteral nutrition at the same time, but it only comes in these fixed volumes. Clinomix uses calcium chloride. As far as I know, there's no problems with that. We don't have information on additive stability in many cases, and there's always the risk with the Clinomix of not breaking the seal and infusing it without doing that. Again, I would add a con. It's just a little too easy to order it. So for developing a parenteral nutrition regimen, let's say that you want to give 25 to 35 calories per kilogram per day, and I'll talk in the critical care section more about how to calculate calories and what formulas to use. This could apply to enteral nutrition as well. Some say that less calories is better, so permissive underfeeding, kind of in lines with we don't eat as much when we're sick. If patients have an elevated BMI greater than 30, you would give them fewer calories, like 22 to 25 calories per kilogram based on an ideal body weight. Much of this is based on expert opinion and not based on evidence. We really don't know the ideal amount of calories for especially critically ill patients. You want to think about calories. You also want to think about how much fluid to give. Again, we talked about 2,500, sometimes 3,500 mils per day for maintenance. You don't want to use parenteral nutrition for fluid resuscitation, obviously. I've caught a few people trying to do that. It's not a good idea. You want to think about protein. Normally, you're going to give 0.8 to 2 grams per kilogram per day of protein. And not only do I think of all these parameters, but I think of them kind of in this order. So for the protein, if you have a patient with kidney disease, if they're not being dialyzed, you're going to give them less protein. But if they are being dialyzed, you're going to give them more protein. They're going to have increase in their protein needs, and that's talked about in your book. I consider the calories from protein. They provide 4 calories per gram of protein. Some do, some don't. I don't know the answer to that, and I don't know that there is an answer. I'm more concerned with overfeeding than underfeeding, which is why I count calories from protein. But if you get 20 different experts on the topic, you're going to get, 2 different, some will and some won't. So there's not evidence to really guide us in terms of should we or should we not count the calories from protein as part of your total calories. Protein buffers a 3-in-1 parenteral nutrition, so you want to keep that final concentration of amino acid between 2.5% and 4% for stability reasons. You want to provide about 20 to 30% of your calories as lipid, provides 10 calories per gram. You could do a little bit less. You could do a little bit more if you needed to for a short period of time. You can give more calories or less from lipid. You want to provide the rest of your calories as dextrose, which provides 3.4 calories per gram. Be careful that you don't infuse. When you calculate your total amount of dextrose that you're giving in a 24-hour time period, do the math to make sure it's no faster than 4 to 6 milligrams per kilogram per minute, because that's how fast we can metabolize it through our liver. If it's higher than that, you're going to cause hyperglycemia. And in some patients, closer to 4 would be better if they're experiencing hyperglycemia. So just a little double check there for how much glucose you're infusing. So for a central parenteral nutrition in a 70 kilogram patient, you might have a total calories of 2,100 calories. We're going to give them 105 grams of protein. That's going to give you 420 calories from protein, and then 500 calories from lipid, which is 25 to 30%. If you take your 2,100 calories and subtract your calories from protein and lipid, you come up with 1,180 calories left, and I'm going to fill that in with dextrose. So that's about 350 grams of dextrose that I'm going to give in 24 hours. You can do the math to make sure that that's no more than 4 to 6 mg per kg per minute. For a peripheral parenteral nutrition, unlike central, which is guided by the patient's nutritional needs or what you estimate their nutritional needs to be, peripheral parenteral nutrition is guided by the final concentration of dextrose and amino acids to maintain an osmolarity less than 900 milliosmoles per liter that you could administer peripherally. The final concentration of dextrose is usually 10% or less, and amino acids is between that 2.5% to 4%. You want it within that range, again, for stability. You also have electrolyte restrictions. Calcium should be 5 milliequivalents per liter or less, and potassium should be 40 per liter or less. So for calcium and phosphate precipitation, the risk is pretty low if your calcium is less than 6 and your phos is less than 30 within your formula. Calcium chloride precipitates more than gluconate, so you want to avoid calcium chloride. And again, your final amino acid concentration should be 2.5%. This forms soluble complexes with calcium and phosphate and can prevent precipitation, and it's a buffer to maintain a lower pH, also to prevent precipitation. You want to keep it cold because as your temperature increases, so does your risk of precipitation. And filters can decrease the risk of embolism, and the filter size will depend on whether it's a 2-in-1 formula or a 3-in-1, which has the lipids. The filter is going to be bigger for a formula with lipids going through it. You're going to inject phosphates first and then mix everything else, shake it up really good, and then you're going to add your calcium last after you make sure you shake it to prevent that precipitation. So some complications of parenteral nutrition. You can have catheter-related infections, most commonly with gram-positive organisms like Staph aureus. You can also have Candida causing this. You can have gut atrophy because you're not feeding your gut, and this can also increase your risk of bacteremia. Overfeeding can cause hepatic steatosis or fatty liver, can cause hypercapnia, where you have too much CO2 production and you're not able to ventilate enough to blow off enough CO2. You can have hyperglycemia and azotemia, or an elevation in your BUN. You want to monitor for these things. Essential fatty acid deficiency can cause impaired wound healing, but it's really only going to occur if you don't have lipids for at least 1 to 3 weeks. You don't have to give lipids every single day, but you want to give some lipids. Other complications, refeeding syndrome in acutely or chronically malnourished patients. So this is associated with a reduction in phosphate, potassium, and magnesium. It can be life-threatening. It can cause cardiac and respiratory dysfunction. So the patients at risk are patients with anorexia. They don't have to look anorexic. They don't have to look cachectic. It could be patients with anorexia that haven't been eating well for the last 2 or 3 weeks because they haven't been feeling well. Maybe their heart failure has gotten worse, or their COPD has been progressing. Patients with alcoholism that can be malnourished but don't necessarily look malnourished. Cancer, chronically ill patients, again, patients with heart disease, lung disease. Poor intake for 1 to 2 weeks, or weight loss. So this is a broad spectrum of patients that can be at risk for refeeding, and you wouldn't want to miss it. You can prevent it by infusing half of their calories and that initially, and then advancing it over several days to their goal. So you don't necessarily start them out at their full calories. You start them lower. Provide more phosphate, potassium, and magnesium, especially in that first week, and you're going to monitor daily and replace as needed. You also want to monitor for infection. You want to monitor their fluid status, their weight, are they edematous, their vital signs, their ins and outs, their temperature, to monitor for their fluid. Do they need more fluid? Do they need less fluid? You can check prealbumin for chronic nutrition support in patients who are not critically ill. You can measure that. Monitor blood glucose, their electrolyte and acid-base status, their triglyceride, and you want to withhold lipids if their triglyceride is greater than 400 to avoid pancreatitis. And the biggest thing to monitor for, especially in hospitalized patients, is their readiness for enteral or oral nutrition. Let's get them off of these products as soon as possible. That's my last slide. So we'll take a 10-minute break. I'm finished about 4 minutes early, so we'll take a 14-minute break, and then I'll start back up with critical care. Thank you.